Good evening, and welcome to tonight's first event of the self-advocacy series, Advocating for Yourself, Transitioning to Adult Cleft Care. Tonight, I'd like to introduce our speakers. First, we have uh, Paul Big, DMD, a general dentist and director of special care dentistry at A.T. Still University, Missouri School of Dentistry and Oral Health, who helps those with craniofacial anomalies and other differences through dental care, research, advocacy, and education. Secondly, we have Ethan Richlack, a medical student at the University of Pittsburgh, researcher and global care advocate, whose research and advocacy efforts are focused on the intersection of clinical care, psychosocial outcomes, and global health policy. Ethan and Paul, please take it away.
All right, welcome. Advocating for yourself, transitioning to adult cleft care. I'll let you take I think you have the slides, Ethan, so I'll
Yes,
let
I
you
do.
advance them.
Yeah, so we'll start off with some intros. And I think I speak for me and Paul when I say we're honored to kick off this webinar series. It's really, I think, going to be great for a lot of people. So we are honored to try and start off on the strong note here. But my name's Ethan. I was born with a unilateral cleft lip and palate. I went to The Ohio State University for undergrad. I'm now a med student at Pitt. I'm also a longtime Operation Smile volunteer. I have a photo here of my friend Evelyn, who I met in the Philippines on a surgical program. I'm also doing a lot of research at Pitt with our cleft team. And so I'm excited to talk about adult care and give some wisdom and advice for some patients. So, yeah. Then,
And then my name is Paul Big. I was also born with a cleft lip and palate. I went to Washington University. Then I went to Case Western Reserve University's dental school for dental school. And then I did extra training in general dentistry focused on people with various disabilities, including craniofacial anomalies at my general dentistry residency at Erie County Medical Center in Buffalo, New York. And then now I currently teach dental school students how to treat those with a variety of disabilities, including those with craniofacial anomalies. And that is my baby photo there. And then my institution I work at in the lower right.
all right. So I wanted to do a poll. We're gonna try this real quick just to get a sense of, oh, can we do that, Aaron? Let me see. Um,
Okay, I'm not sure if we can set up a poll right now. I could actually. Let me see if I can do that really quick for you.
we just want to know if, the breakdown of providers versus affected individuals versus parents, anything like that. So we love to just see who we're on with before we start and can kind of tailor it as needed. Trying to do a little Q&A situation.
Absolutely.
Well, we can get to that. In the meantime, we'll keep rolling. Oh, you can type in the chat. Oh, awesome. Yeah. Type in the chat where you guys are coming from. If you're a patient, a parent, a caregiver, a provider, please let us know. Yeah, big range here. I already have a caregiver, a patient, and a provider. Sweet. I'll let these roll in as we continue. But we will move on. So we want to start off by kind of talking about what adult care even is. Like, what are we transitioning to here? Which is a great question. And so there's not really a consensus definition about this. It's kind of, I think, colloquially known that sort of once you quote unquote graduate, I'm not a fan of that term, but for lack of a better term, graduate from care, and you're kind of being seen on an as needed basis, I would say is probably what constitutes, pediatric versus adult care. And that really means that for patients, the care is initiated by them And so there's no more yearly team visits. They have to kind of take the lead on when they want to come back if a problem comes up getting back to the clinic. And so for most patients, this occurs after, like their secondary like revision rhinoplasty or after jaw surgery or something like that. And sort of after about a year of follow-up, they kind of move into this as needed basis for adult care. Additionally, hospitals might have like some age restrictions, which kind of limits the ability for patients to stay with their team, which is a whole nother interesting part of this. And so patients might have to go to a completely like adult plastic surgery team who might not be, specialized in cleft specific care, or might have to travel a further distance to their nearest cleft team that can actually take care of them. And so as we think about how we're transitioning from pediatric to adult care and what steps need to be taken and what resources can be given to patients, I think the GOT transition framework has been really helpful for helping to understand this. And it's kind of the de facto what we're going to be doing. And so uh, I'm not going to read this whole definition, but basically the plan is that we're transitioning patients from, a caregiver, family-centered method of care to a more patient-centered method of care where patients are becoming more actively involved in their care, guiding their interventions and surgery, and also getting involved in the planning transferring eventually to sort of this as needed basis. And so they laid out two goals for this. The first goal is more for the patients. I think the second goal is more for us providers. So the first goal to improve their ability to work with and without special healthcare needs to manage their own healthcare and effectively use health services. And so I think that's a lot of what the we'll talk about in terms of self-advocacy is how to have our patients meet that goal and how do you prepare yourself well to be able to like, hit the ground running when you transition out of pediatric care. And so we get into some of these self-advocacy strategies. These are the six core elements that were laid out by like the GOT transition framework. Again, I'm not going to read all of them for brevity's sake, but I think the three that are most applicable to patients is number three, four, and five. So being ready to transition at some point needs to happen, and this takes some time. And I think the guidance is to start early, and we'll get to that. But ensuring that patients are knowledgeable about your condition, what it means to have a cleft, how it happened, why it happened, what it means for the future, I think are really important to understand as you begin to get more independence and eventually are independent in guiding your healthcare going forward. I also think planning, so being involved in the planning of when are we going to transition, when are we going to have my final surgeries, stuff like that is super helpful to A, learn sort of what goes into that decision and B, to kind of come up with future-oriented plans for once you're out of pediatric care. And then lastly, the transfer of care. We'll get into this more, but these are things I think of like logistics, like where am I going to go get this care? What's the easiest thing for me? Is it going to an adult team? Is it traveling an extra 2 hours to the nearest cleft team? What's insurance looking like? Stuff like that. And so I think those three are mainly for the patients, and then the other three are more on the provider side, things that some of which I think we already do, but I think, as always, could be improved a little bit more. Um, and so, just to kind of give some really granular advice for the patients here on sort of what self-advocacy strategies can be used to meet some of these core elements so that we can prepare you the best. And so, like I said earlier, starting early, 11 to 14 years old is the official like recommendation from the GOT transition team. I think this involves like education stuff. I think the bottom bullet point is something that can be started very early, like learning about cleft conditions, what happens, why they occur, what surgeries and treatments you've had in your life, kind of reflecting on that so you have a better understanding of what you've been through, which A will be helpful if you have to go to a new provider. It's very nice to be able to tell them specifically sort of what's happened to you, for lack of a better phrase, and what you've been through. And I also feel like it can be somewhat therapeutic as well, just to know the history of everything that's happened, and will prepare you for sure. And I think as you get a little older, that's when you start getting into like the shared decision making. So instead of I see it all the time in clinic where, you have the teen or the young, 11, 12-year-old who is indifferent about everything and kind of has the parent take the lead on like what they want to get done. And I think it's important as you get older to join in the conversation more and provide your input on what really is bothering you or not bothering you for the sake of future surgeries and stuff like that. And so and I think as you get to the end of that spectrum, things like learning how to do like these tasks, like how do we even schedule this appointment? Like who's calling me? Do I have to go online? How does insurance work? Accessing like your records or stuff, or your my chart notes after the appointment. Just learning how to do all of that, I think will come in very handy as you get older for not only cleft related care, but also just healthcare in general, which is super important. So those are some of the readiness ones. And then I kind of group these two together, and these ones are a little more specific, but I think insurance is super huge. I think Paul will hit on that a little bit later. But as we know, the insurance coverage for children with cleft conditions and craniofacial differences in general is a little dicey, and so it's important. I put at the bottom kind of to know your rights. Like in my state, what am I like obliged to get? Do they cover all craniofacial care as deemed necessary by my physician? Or am I going to have to get into an argument with the insurance company about this? Sort of understanding that for you and your situation, I think as you get older will be super helpful. And then, like I said, for planning, understanding where you can get your care, what's available around you, what do you mind going to an adult plastic surgeon? Do you want to stay the cleft team? Sort of how that looks for you and sort of thinking about all of these things, I think will set you up for success to meet these three bullets of the six core elements. And I think after that, it's up to us providers to kind of fill in the rest of the gaps there and make sure things go smoothly. And so those are sort of my tips. And I apologize for the bit of the rant, but we wanted to really focus this on the needs of the attendees and the people who registered, and wanted to really hone in on the questions. So during the registration, we asked a bunch of questions or asked for like questions, and so we have a bunch that we will on to tackle that people in the community had concerns about that sort of apply to this. And I was going to let Paul take it away for most of these questions that we have pre-prepared, and then we'll open it up later.
All right. So, and I think all of that's really important. So it's one of those processes where I it was one day I was at Children's, the next day I'm like looking around trying to figure out who I'm going to. And so I think any sort of conversation where we get more involved of, okay, now we're transitioning. You're not going to be this team because for X amount of time because they don't take adults. That's very important. So one of the questions was related to insurance concerns for cleft care. Very difficult. A lot of times when you try to submit a claim or try to get yourself coverage, you really want to get into that medical necessity. If you have an ICD-10 code, so that just means something that identifies on a list of many conditions what is your condition. So cleft palate, there's cleft lip with palate, bilateral cleft lip and palate. If you look up those codes, usually your provider will take care of that part. And then what's your quality of life hindrance or concern? And while it should be covered under medical, I had growing up a problem with a jaw surgery. The insurance companies were saying it's cosmetic. We were saying it's a medical necessity. We even talked to some lawyer who said you need to argue about the medical necessity and that these are contradicting terms, and when such things occur, it should hopefully go towards the patient. Even then, we didn't get that covered. And it's unfortunate. So it's one of those things you run into this problem talking with your providers and even having them write a petition letter. There's times when I had to, as a provider for a dentist for a totally different issue, let's say they didn't take care of like the partial, like something to replace missing teeth. which a lot of people with clefts have. I have to go and be like, this is due to the birth condition. This isn't due to something else. This is a medical necessity. So it's a very tricky conversation. I don't have all the answers, but those are some of the good starting points to get at. Next slide, please. So another question was, which U.S. teams provide transition of care preparation? What tools do they use? And all these questions are really great. Recently, we have started at the ACPA. I was part of the Standards and Team Approval Task Force, and we looked at transition and adult care and made its own standard. So before this year slash last year, there were certainly implications that you would follow up. Certainly the parameters discussed it, the most recent parameters, but which define ways of helping to take care of people with a cleft and other craniofacial condition, but it wasn't specified in the standard. And so this is something where now teams will need to address that. And hopefully by their next approval, they at least should have some ideas. And to really emphasize that, we'll spend a whole nother lecture series, not series, but webinar focusing on getting those providers, because this was probably a provider question on how are you going to transition? What are some key elements that we were discussing earlier? So stay tuned if you're a provider. There's another webinar in August to get into that more details, but we will get into some of the basic elements so that you can start drafting it, gain some ideas, and then come with further questions, queries, and so on. Next slide, please. What would the development of a sustainable program for patients transitioning to adult care look like? So Ethan certainly started into a lot of really good elements of transition. And this is another framework that I've seen with dentistry as well as those with other like neurodevelopmental disabilities, which is really starting at adolescence. You really want to get them discussing about their care, taking more ownership, like Ethan was saying, which is age 11 to 14. So that's like early adolescence. So adolescence is early 11 to 14, mid 15 to 17. And then when they become a young adult, that is also called late adolescence. And so you're starting it early. You try to find those adult providers. Really key quarterbacks for your care as an adult are that general dentist or whoever's going to take care of your adult dental needs and the primary care physician. From there, those two providers should be able to get you to proper referrals. They can find out, oh, this person takes issues with your nose. This person deals with your speech. This person, they can get you to those right providers. You confirm that it's starting to occur or that you have a game plan, and then you send those records over, and then you have a list of referrals. And at least with that standard we were talking about before, they should be made available to get referrals somewhere. So either that pediatric team's taking it, they can do exceptions, and I'll get into an example story. Or they have a list of people who deal with adults and that can take you on. And that's the part of the intent of Standard 4. Next slide, please. So this is an example for pediatric to adult dentistry. You're calling to see when's the best time to transition. You're asking that to your current dentist. You call to see who's taking your benefits. Not all adult dentists take the same benefits as children. That goes with any other child to adult providers. You prepare by maybe asking, can you go see the office, take a look, go and meet the providers at some point with that new patient exam, and while you're still at your pediatric office, so that if that adult office doesn't work right away, you can find a different one. check to see if they've gotten that referral and get those records over, and then lead into exiting out of the one clinic and transferring to the other. And so that is one framework. We'll get into this more with that Provider Pacific one in August. Next slide, please. What's the best way to search for an adult care provider? Look to see who takes your insurance benefits. Ethan, do you want to talk to the other resources you have there?
Of course. Yeah. So it is tricky, and I've heard a lot of stories of a lot of patients calling around the country trying to figure out where they can go. And I think the ACPA Teams website is actually a great resource and has the listed ages that teams are able to treat. I'm not sure how up to date they are or how logistically, granular it gets for little different cases, but I think that's a good guide to at least start off. And we also, like I said, I'm heavily involved with Operation Smile. We recently made a little map on Google where it has sort of all those teams on the map around the country. And it's kind of color graded based on how old they are able to treat because not every team is, 18 plus or nothing. It's very much, some of them are very random, like 33 or 50 or something like that. So they're all a little bit different. So there's a really helpful map, I think, that can kind of guide patients to see what's the closest place around me and how old can they go. And like we have here at the bottom, that all these resources will be shared at the end on the slide so people can access that. I also think too, getting in contact with a provider from your cleft team just over email or something like that. A coordinator typically, I feel like, knows where they are referring people out to. For if it's not going to be at a cleft team, they at least know who sort of locally is their go-to person or people who they've been referring out to, which would always be an option. So.
How do I find an adult dentist skilled and comfortable with treating adults with cleft and craniofacial differences? It's very tricky because there isn't a craniofacial dentist specialty. And so one group of people who deals with a variety of disabilities are those with special needs, special care dentists. They aren't, they have extra training and they've broadcast to the world they're willing to take on people with any disability. I am in that field, and we do deal with people with clefts as well as other conditions. So if there's issues with behavior, if they're syndromic cleft or they have a cleft with another condition, we deal with that all the time. General dentists should be able to too. Every dentist and dental school does learn about these craniofacial conditions to some degree. The special care dentist will get it more often, but it's few and far in between. There's not a whole lot of us. Prosthodontists are also helpful, are people who specialize in full mouth, dental rehabilitation. So if you have, let's say you have a communication that needs to be closed with a prosthetic or something that is a retainer that comes in your mouth or out of your mouth that replaces teeth, those are people that would help too. You want to double check your insurance. Not all of these providers take certain insurances, so you don't want to call, get that new patient visit, and then realize that they're not in your benefits, and so you have to pick someone who that is. If you're in St. Louis, call me. All right. I'm happy to help you out with that. It's a tricky conversation because of trying to find someone if you're at least not in St. Louis, because it's like, who do you even look for? I'm a dentist, and the only way I've been able to navigate things really great is because I actually have the background to do it. And I can appreciate how difficult it is as an adult to find what you need and know who to even ask. So, because it's not clear cut. So my email will be at the end. Email me anytime. Happy to help. Next slide, please. And our email will be at the end. What is being done to train dentists and orthodontists and cleft care that take care of adults? All dentists should be able to treat people across the lifespan. But that being said, as I alluded to earlier, there's not a whole lot of information on adults with craniofacial conditions and what their dental needs are. So one of the big things I think Ethan's definitely doing, and I hope to do more, is understanding the adult needs and what's going on that landscape. Because once you graduate from a team, which I don't like the word graduate either, you still have ongoing needs. And so more research is necessary to really help. But you got my contact should you need to ever discuss further. And I'm willing to even talk to your person that you're going to see and provide support as needed. Orthodontists, a lot of dentistry and orthodontia are very similar to children and adults, but there are obviously distinct differences, and I can go over some of that from a dental side. Let me give you an example of how hard this is sometimes. I had what looked like an infection from a tooth. I thought it was a tooth infection because that's what I do. I'm a dentist, and I look at this red bump and I'm like, oh, that's an infection. And my friend who works at a dental school with me, because I have all these people in this dental area. Yeah, that looks like an infection. We go and get the imaging. Turns out it's my cleft, not my tooth. I then go to an oral surgeon who's like, yeah, I can close this up, but I'm going to need a plastic surgeon. I had to get a special referral from the oral surgeon, even though by this point I figured out it was a cleft infection to go see a pediatric craniofacial plastic surgeon. I'm still working on this. We find that it's very difficult to deal with. There's not a lot of data on why is it occurring and what type of repair did I have initially with my surgeries, how well do they do? Questions that we need more info on. And so we're going to try to do more. And unfortunately, in the meantime, there's a paucity, a lack of information to help us out. But that's also why my email is at the end too, because I feel you and hopefully we'll figure something out. Next slide, please.
I just want to add on a few things here.
Yeah,
I think
absolutely.
outside of orthodontics, in terms of other specialties, I think a lot of I forget who I was talking to about this, but I think it might be here at Pitt where we know where some of our patients are going, and we are able to like actively talk with like we keep a friendly relationship with some of these adult providers who might not be cleft trained specifically, but we kind of, when we facilitate that and we're the ones sort of telling them to go there, it opens up a way for communication where if they have issues, like they can call the team and we can give them our advice or our input, which I think is also something great when we focus more on this transition and think about it more. When we refer them out to an adult plastic surgeon or something, they have questions about how to do something, they can just call our craniofacial surgeon. And so I think that's also a really good way. In the meantime, as we hopefully have more like training on this come up in the future, I think just fostering collaboration through really well done transitions of care can be super helpful. Um, yeah. And I also love that you were talking about sort of the history too, which is why I said it's important to know sort of what your surgical history is and dental history is super helpful. And a lot of the older patients that I'm now like looking at reviewing charts on, it's not really well documented. It's really hard. So I think encouraging our patients while they are in care to kind of understand better, okay, like specifically, do they have a furlough, straight line, like those types of things are really helpful for a new surgeon when they're evaluating you or a patient. And so I think we can do better at making sure patients are more informed on sort of their surgical history, their interventional history, stuff like that too. So thank you for bringing that up, Paul. I can do this one if you want. Yeah, so this question was from a parent talking about how it's hard to let go of the reins and let her twins take control of their care. And what suggestions for young adults to help with the transition process? And so this is a great question, and something I feel like we run into a lot. And sort of goes back to what I talked about, why it's so important to start this early, like 11 through 14. Like I think it's super important to slowly build up to it. When they turn 18 and just flipping a switch to from doing nothing to now being fully responsible, which I know it doesn't always happen like that, but in essence, I think that can be very concerning, and a lot for the caregiver and the patient. And so I think starting this process early, easing into some of the shared decision-making processes, getting patients involved in the clinic visits, talking about surgeries, making sure they are fine doing the surgeries and talking about them about what it means, the planning of things is super important. And again, that educational piece and learning how appointments are made, learning about their medical history, I think slowly over time they'll build up to a point where when it's time, you can trust them and just let them take the reins and that they're well educated and know what's going on and what they need to do in the future. And I think part of it too is the team's responsibility to help make sure that this is feasible and safe and easy. So I think it's a collaborative effort, and I know caregivers it's super challenging to sort of take your hands off and let things take their course. But these are some of my advice, and I think it goes back to a lot of what we talked about. So, and that was the last pre-plan question. So I guess we can open it up if anyone, I don't know if you're able, I don't know if you can raise your hand and we can unmute you or just in the chat if anyone has questions, comments, concerns, advice, wisdom, we would love to hear. I know some of you in the chat and I feel like you guys definitely have something to share. So um, would love to take any questions now.
And before we get too into the questions, I want to say it's really nice your team does that with the adult plastic surgeons, because I think that's actually a really great idea. And that's not happening in every state that I'm aware of. So being able to have that direct communication and then having that referral is actually a good way to foster it. And that's the intent of Standard 4. So hopefully more teams will follow that.
Any questions? We're open books. So I guess me and Paul did too good of a job. We answered any possible question. Oh, there, Dr. Strauss.
It's the concept of a children's hospital part of the issue. I I deal with pediatric dentists all the time, and I will say if we don't have the children's hospital, where are the children going to go? So it's definitely needed. And can they expand? Because, like, for instance, pediatric dentists have they put in their specialty manual that they see people with special healthcare needs. So that includes people with like a cleft and even into adulthood in theory, even though they technically would like to have the patients with a permanent or adult dentition see an adult dentist. But yeah, I mean, I would say without them, we would be in a worse off. But I think if they could do even more by expanding like people with disabilities on top of children, but then you also have the concern, there's certain conditions that the pediatric people feel comfortable with, but then there's certain conditions that they don't feel comfortable with. So I think that's a really great question to elaborate further. Ethan, any thoughts on that one?
Yeah, I mean, I feel like Dr. Strauss, I get what you're getting at. It's hard. I think cleft is uniquely positioned as sort of a lifespan condition. And so it is challenging, but there's also other ones. Like, I don't think we can really use it as an excuse because there's things like congenital heart disease, things like IBD that have big, like, pediatric and adult sides of things. And we just don't have that in cleft and craniofacial care for the most part. And so while it definitely would be nice to have patients who are, craniofacial surgeons who are comfortable with cleft regardless of any age, that sort of training layout at this time for that is pretty pediatric focused. And so I think it's hard and we're in a tough spot, but I think that's why we have a lot of interest in this and a lot of attention being put into it in the future to try and make this as seamless as possible. We can't change, how things are done for the most part on a big scale like that. So I think we just got to work with what we have and do research. And as a ACPA community, I think it's our job to come up with some good plans. So we will do that. Then we have Johnny. He says, I wonder what suggestions you have to deal with the grief associated with transitioning for both child and parents. That's a great question, Johnny. I think personally, I'll start. I think the psychologist on the team needs to play a big role in this time period. Especially, I mean, they're already playing a big role as patients get older and into their sort of late adolescence. Um, and so I think having them on board, making sure things are going smoothly, answering questions, providing, you know, therapeutic services if they're needed at that time is super important. And then I think every patient with a craniofacial difference, or really any person in general, should have like a therapist. And so I think doing that and having someone like that in your back corner as well. But it is tough. And I think too, I love that parents were added into that because just like the question we saw, it can be really hard for them to sort of let go and not have they've been controlling everything and have their finger on the pulse for 20 years, and so I think it's difficult for them as well, so we need to look into that more as well. I don't know if you have thoughts on that one, Paul.
I do. So personally, I would lucked out where I was able to volunteer for the team that I got treatment from. So I thought that was a really nice moment to still be connected and give back. And sometimes allowing the team patients that they feel like they have a real passion to still be connected, to be able to be self, uh, kind of telling, like self supporters, telling people about their stories. Of course, with telling stories, it not everyone has the same story, but it's one of those things where it brings hope. It allows people to feel a little bit more, yes, I'm done with care, but now I'm helping out. So it shifts the focus. So really great question. Next question is, what do you all feel are important elements included in the summary document that we provide young adults upon transition, and what are you feel are the most important specialties to have a part of a local cleft team? So I'm just clumping them together because it's about that team composition and the summary document. Really, each person's different. Every team member is important. According to the standards, there are three specialties that need to be in every team for a cleft team, which is orthodontics, plastic surgery, and the speech and language pathology. So that's like our requirement, but each one plays a different role for people with a variety of craniofacial conditions. Some people may be dealing with more psychosocial issues, so they need the psychologist really emphasize on a particular visit, whereas some people have a bigger cleft and they need all sorts of other services. So, and a team, I like the idea of team not only being the people you see at Cleft Team, which of course is team proper, but anyone who's taking care of that child is all connected. So your local speech pathologist, your dentist that you see that maybe isn't on the team but does your cleanings because you drive 2 hours away for your team visit. You could do 4 hours a week or twice a year like that. Uh, and so in terms of team composition, everyone's important. And I'm told what are required by the standard, but everyone's important. And then what's important to put in the summary document, I think there's two different parts to that. Summary doc with transition are putting in pertinent variables. I had this type of surgery, this surgery this time. If there was any sort of complications, this is how I am with speech. This is how I went through orthodontics once. I had my hearing is doing fine. I'm currently still seeing someone who's in therapy because I agree therapists are huge. And so there's a lot, every element is important. That's why in the parameters we list all these different views, and it's more about what their patient needs are and not so much which um uh which provider is of the most importance because they're all important. So Ethan, care to add any additional comments on that?
For sure. Um, I think I'll start with the transition summary document. This is something we've been talking about at Pitt as well. That I think, as I said earlier, like it's nice for the patient to know, and it's kind of unrealistic to think that they should be asking, their whole surgical history and expected to like write it down or memorize it. So I think what we're thinking about is how can we share that with them in a quick and easy sort of way, like really briefly what surgeries they've had, when they've had them, specifics about them, complications, stuff like that. I think that will be super important for any surgical related concerns that come up later. I know in my work so far that I've seen, there's a lot of situations where patients who are above 50 who are coming back, like it's really hard to know what happened, basically. It's not well documented as we've switched from like paper to EMR, and they don't really know exactly what happened. It's been so many years, and so it's really hard to approach that surgically. I also think speech therapy, dentistry, orthodontics, stuff like that too, just a broad history. Um, and then I also would say like who the original cleft team was, like surgeons, like people's names, if they are still practicing, can kind of like reach out and clarify things. Um, that's sort of what I think should be included, and as well as a bunch of resources. I think that's like that what I talked about was sort of like the patient history part of that, which I think we should be like giving to patients when they transition to have. And I also think in terms of like a summary document, a lot of resources for things to look out for was another thing that we ran into a lot in our early work, where patients would come back and then there'd be things medically that they didn't think would impact their ability to get cleft care, but do. A lot of times it is dental stuff. We have a lot of adults who've come back who are unable to get surgery because of their sort of dental needs. And so those have to be kind of kept up with in order to address a lot of cleft related concerns. And so stuff like that, like what to look out for as you get older, what to sort of stay on top of, I think would also be super helpful to make patients aware of that. And then in terms of important specialties to have as part of the team, I agree with Paul. I think the big three of speech, ortho, and surgery. But I mean, I think it should be a big four, including psych. And I feel like it is now maybe a requirement. But I think those four are truly essential. And I agree that the team is a lot wider than the team in the clinic. And so I think us as a community, I love Paul mentioned sort of community involvement and getting involved with helping out at the clinic. We've seen some great outcomes from patients who've like taken, their experiences and try to help others like them. And so I always think that's the community surrounding Cleft is really great. And so I think that's a big part of the team as well.
Yeah, and I mean, just it's interesting because with the standards, if that's not on the team, then having a referral source present is something where you refer to like an entity, like a practice. So psychology St. Louis. Okay. There's not a practice like that, but they have to either have it for your needs or they have to be able to list someone who is taking care of that. And I think to allude to what Ethan's saying, there's definitely certain milestones where you need to have the psychologist involved. So definitely, I think even if the core three have been, set, I feel like we're starting to creep into having more core fields, and one of them alluded to is that psychological neurocognitive assessment, for instance. That's usually done by psychology or some other provider, whether that's a neurodevelopmental pediatrician, someone who's trained in dealing with neurocognitive assessment that is a requirement. And the parameters and standards, they have moments where it's not prescription based. So some people who are in the lower span of the intellectual capacity are going to need a lot more support when it comes to gain understanding of the care. Maybe as they transition to adulthood, they have someone who's still helping them out, whereas other people may be a different functioning as well. Ethan, any other commentary?
Sorry, I did not mean to raise my hand.
Oh,
I just saw we had Jessica, Dr. Kinelatos, was raising her hand.
oh,
I don't know if she had a question or she also accidentally raised her hand.
well, and she's actually one of the people that I went. Let me see where the attendings are. Yeah, she actually was one of my attendings in residency. She's a prosthodontist. Um, I don't know. Are you allowed to unmute yourself? Let's see if we can. No.
Oh, it was an accident.
Okay. Well,
It's okay.
yeah,
Shout out Dr. Canelatos.
yeah, if you want to speak about uh, yourself too, you're welcome. And anyone else who wants to chime in, feel free to do so. No pressure though.
No problem, Anisha.
Yeah.
Well, we appreciate all the questions and comments. We're happy always we'll have our evals at the end. I'm always happy to talk about this for a long time, as you can probably tell. So, um,
Ditto.
I wanted to share some last resources and stuff. And so, like we kind of touched on, I think there's a lot of community around cleft care and craniofacial care. Um, and so here's just a list of the ones that I can name on the top of my head. But I do think for patients, it's always nothing bad ever comes from when they like get involved with like a cleft NGO or something like that. Like I've seen the biggest transformations from that, and I always um, encourage patients to like get involved with that. And I think in terms of self-advocacy, it's a great way to have ownership of like your condition and your care. Just you learn so much, you're able to help people, and so always recommend with your poison, of any of these amazing organizations as well. And so we have a list here. And then some resources here. And so I will put these in the chat as well. But this is the team's website. This is our Google map with all the adult teams around the country. And then I also put this gout transition of the six core elements if anyone wants to look at that. And then there's this patientadvocate.org website that has some actually really good like self-advocacy like tips and like one pagers, which I thought were very helpful. It's a little more general medicine specific, for sure. I think a lot of sort of the basics can be applied to anything, and so I think it's a great resource as well. So I think that's it.
Thank you, and Dr. Clanwa, it's nice to see you too. And um, I think I can defer that to Aaron. Is there any way we can send like maybe our slides over to um, so that, or at least the links to get to the attendings?
Yeah, if you send me the document, then I can get it emailed out to all of our registered attendees.
Wonderful. Thank you all.
Mhm.
Yeah.
Yeah. Just want to say thank you again, everyone, for attending tonight. We do have our next event of the series is called Rewrite the Narrative, Media Literacy and Positive Representation. It's scheduled for Thursday, August 13th at 1 p.m. Eastern Time. Registration is now actually open. It's on the website, and we will be sending out an email sometime soon with that registration information. So we hope you'll join us then.
Yeah. And last plug for our webinar that we'll do for the providers in August. I think go dive in a lot more into the research side of things and what we actually know from the data and can have big time discussion about where we go from here. So yeah, thank you, Aaron, and thank all of you.
Thank you and good night.